My name is Jeff Lancet. I'm from the Moffitt Cancer Center in Tampa, Florida, and I'm here at the SOHO 2019 annual meeting. And I'm here today to argue that traditional induction chemotherapy is not yet ready to be replaced across the board by HMA plus venetoclax combination in older patients or in patients with adverse biology AML. And of course, there has been a lot of attention paid recently to the development of HMA plus venetoclax combinations in older patients with newly diagnosed AML, and for good reason. The combination has been very successful with high response rates and encouragingly high survival rates amongst patients who would traditionally not be considered to be candidates for more intensive chemotherapy, patients who are quite elderly or have significant comorbidities or are frail. Absolutely, this combination works very well for those patients. I'm here to argue against the fact that that combination should be used for all patients, and that there are certainly certain groups of patients in the older age subgroup and even in younger age high-risk subgroups that still benefit from more traditional induction chemotherapy regimens. And I'll start out by saying that despite the encouragingly high response rates and success of the venetoclax HMA combination, we do have to be aware of the fact that the data are still very early. The randomized trial comparing HMA plus venetoclax to HMAs alone has not yet been published, so we're not yet privy to those specific data to guide us as to the exact benefit of this combination as compared to single agent HMA therapy. So it's important to recognize that there are limitations to the HMA plus venetoclax data based upon the relatively short amount of follow-up and the lack of randomized trial data available at this point. I would also like to point out that the main question still persists as to whether we can adequately compare HMA venetoclax therapy to more intensive traditional induction chemotherapy. There have never been any randomized trials comparing the two approaches. And what's also noteworthy is the fact that the trials that have been done with induction regimens, traditional induction regimens, and HMA venetoclax regimens include patients that are quite different. So the HMA venetoclax trials are focusing upon patients who are, again, older, have a lower level of fitness, higher comorbidity indices, whereas the traditional induction chemotherapy trials have focused on a somewhat younger group of patients, typically under age 75, in addition to patients that may be considered bone marrow transplant candidates. Other important differences include the fact that the HMA venetoclax trials did not include patients who had received prior HMA therapy for an antecedent hematologic disorder such as MDS. And the HMA venetoclax trials enrolled primarily patients with de novo AML as opposed to secondary AML. So these are important distinctions to make in comparing the two different trials and raise the point that it's hard to compare outcomes between trials that are enrolling different types of patients. So for that reason, I believe it's difficult to broadly state that we should be changing the standard of care in favor of induction chemotherapy, in favor of HMA venetoclax therapy over induction therapy until we have those types of fair comparisons between trials. Now, I'll also point out that amongst older patients who we might think don't benefit from induction chemotherapy, there are certainly important biologic subgroups that will benefit from induction chemotherapy. Patients that have favorable risk cytogenetics, such as core binding factor types of leukemias. Patients that have NPM1 mutated AML, FLT3 wild type AML. Those patients do seem to benefit from an induction regimen, and a significant proportion of those patients will experience long-term survival. So it's reasonable to strongly consider induction chemotherapy for patients with more biologically favorable acute myeloid leukemia, even in the older age groups. In the younger age groups, certainly adverse biology would consider the FLT3 mutated group of patients, and we already know that FLT3 inhibitors in combination with induction chemotherapy has emerged as the standard of care for that particular high-risk group of patients. So at this point, I don't think anybody would be willing to say that HMA plus venetoclax therapy would be appropriate for a FLT3 mutated AML younger patient. So those are examples of types of patients that would be considered higher risk that would still most likely benefit from a more traditional induction regimen. And then finally, I believe that we need to strongly consider the goals of the patient when it comes to making a treatment decision. And the goals of the patient involve things such as quality of life, time spent outside of treatment, and the goal or the possibility of long-term remission or cure. And these are important considerations when deciding upon a lower intensity type of therapy such as HMA-venetoclax or a more intensive therapy. And the data at this point still support a more intensive regimen giving a higher likelihood of a cure or a bridge to transplant than a lower intensity regimen. At the same time, we also have to remember that quality of life studies that have been performed on a limited basis in older patients who have received more intensive chemotherapy have definitely demonstrated improvements in quality of life with intensive chemotherapy. So the notion that intensive chemotherapy destroys or deteriorates a person's quality of life with AML is not entirely accurate in my opinion based upon the data available. So in summary, I feel that although venetoclax HMA combinations are very encouraging and promising, we're not yet ready to state definitively that that should be taking over as the standard of care for all patients who are elderly with AML or all patients with higher risk biologic features in the younger age group.